We are very happy with my colleague Alessia Luno to chair this session, also as members of the Quality of Care Committee and chair of the Quality of Care Committee. This very important session about EULAR recommendations, and we are very happy to see that EULAR is producing high-quality recommendations. So without any further delays, I would like to introduce our first speaker, Chetan Mukhtiar, that he will speak about the EULAR recommendations for the management of polymyalgia rheumatica and large vessel vasculitis. Chetan has a long and strong interest in the field, so Chetan, the floor is yours.
Thank you very much. This is a privilege. I'm presenting the 2025 recommendations for the management of polymyalgia rheumatica and large vessel vasculitis. And I have to say that I am just the mouthpiece. These recommendations have been developed by the entire task force, and they are listed below. It's their sage wisdom and guidance, especially that of Bernard Helmich, my co-convener, and the methodologist and the steering committee. The task force represents 13 countries, European countries, alongside Canada, United States, and India as well. So without further ado, let us unveil the 2025 recommendations. Can anybody else hear echo? I thought it was my tinnitus, but I can hear it. It's real. Good. You can all hear my tinnitus now as well. So without further ado, these are the recommendations. These are the algorithms for all three of these. I'll wait a couple of seconds so you can all take your pictures. And if you want, I can even pause for you. No, I was going to say, I will take you slowly through each of these recommendations. But before I do that, we have overarching principles. And these overarching principles have largely been carried forward from previous recommendations, but there are some new elements. All decisions regarding management should be made in partnership between the clinician and the patient after an informed discussion highlighting the pros and cons, considering the efficacy, safety, and costs. And this is enshrined in the overarching principle to use alongside every recommendation. We recognize that a diagnosis of PMR or LVV is based on signs and symptoms, and in patients with suspected GC or TAC should be confirmed by imaging or biopsy. We do not encourage the use of classification criteria for diagnosis. And as I said yesterday, there are patients that will fall between phenotypes, and a best fit diagnosis can be used to follow these recommendations for those patients. The third OAP is that patients should have access to education, focusing on the impact of these diseases with key warning symptoms and treatment-related complications. Patients with large vessel vasculitis should be screened for treatment-related and cardiovascular comorbidities, taking into account the glucocorticoid burden that they will receive. Prophylactic treatment and lifestyle interventions may reduce the cardiovascular risk and treatment-related complications. So, using these overarching principles, I will now take you through the recommendations that have been based. Some of them have been unchanged, some of them are new, and they're all based on a systematic review of literature done by the steering committee, and those will be published in EULAR Rheumatology Open shortly. So the first recommendation: all patients with suspected PMR, GCA, or TAC should be referred for assessment to a specialist with appropriate expertise. Patients with suspected GCA should be urgently referred. And that means that we would expect a referral within 24 hours of presentation. We recognize that we have put PMR in, that is the new bit, because we have data from primary care that they are under-investigated, sometimes over-diagnosed, and there may be hidden vascular involvement. We the academic community is divided between the significance of this vascular involvement, but we are united in saying that at least we should know that it exists. Recommendation 2, in patients with a strong clinical suspicion of GCA, treatment with glucocorticoid should be commenced without delay while waiting for the results of confirmatory investigations. But in most patients with suspected PMR or Takayasu, treatment with glucocorticoids can be delayed until the diagnosis is confirmed. We recognize that GCA is a medical emergency. This is unchanged from previous years. We have new data that supports the use of multimodal diagnostics, including imaging and/or histology as necessary. We recommend that confirmatory investigations for PMR and TAC should be done, and we discourage the use of a trial of glucocorticoids as a diagnostic test. 3 pertains to the role of glucocorticoids in polymyalgia, and in patients with new onset PMR, oral GC should be used for induction of remission at an initial dose of 15 to 25 milligrams per day, tapered to 10 milligrams per day at 1 to 2 months, and with the aim of stopping glucocorticoids within 1 year. In patients with relapsing PMR, therapy with GC, and in all cases when I say GC, I mean prednisolone or prednisone, should be restarted or escalated to at least the last effective dose, followed by individualized taper. And the glucocorticoid regimen should account for patient and disease factors and the use of adjunctive therapies to use the minimum effective dose. 4 pertains to new onset 4 pertains to glucocorticoid use in GCA, and we're saying that in patients with new onset GCA, glucocorticoid should be used for induction of remission at an initial dose of 40 to 60 milligrams per day, tapered to 15 to 20 milligrams by 2 to 3 months, with the aim of stopping therapy within 12 to 18 months. This is largely unchanged as well from previous years, and we've said that in case of major relapse, by which we mean structural change of an artery or the presence of ischemic event, and this has been defined in previous years, therapy with GC should be reinstituted or the dose escalated as per new onset disease. For minor relapses, those relapses that don't fit the definition of major, the dose of GC should be increased to at least the last effective dose. Subsequent tapering should be individualized in all cases. 5 pertains to the use of glucocorticoids in Takayasu, and there is a nuance here. We've said that in patients with newly diagnosed active Takayasu, recognizing that not all patients with Takayasu may have active disease when you see them, GC should be used for induction of remission at an initial dose of 40 to 60 milligrams, tapered to 15 to 20 milligrams within 2 to 3 months, with the aim of stopping therapy with glucocorticoids within 12 to 18 months. And just like GCA, if there is a major relapse, then therapy should be reinstituted or the dose escalated as per new onset disease. And for minor relapses, it should be increased at least the last effective dose, and in all cases, subsequent tapering should be individualized. 6 pertains to the use of adjunctive therapy in polymyalgia rheumatica. And we are saying that adjunctive therapy with interleukin-6 receptor inhibitor, and specifically tocilizumab, may be considered in selected patients with new onset PMR, and these are data that you saw yesterday from Bonelli et al. Adjunctive therapy with an interleukin-6 receptor inhibitor, preferably sarilumab from Spira et al., or tocilizumab from Devoshel-Pensek et al., as an alternative should be considered in selected patients with relapsing or refractory PMR. And our friend methotrexate always makes the cut. Methotrexate may be used as an alternative to interleukin-6 receptor inhibitors in both groups of patients. 7 pertains to the use of adjunctive therapies in GCA, and we now have really good evidence for this. Adjunctive therapy with tocilizumab or upadacitinib should be considered in patients with GCA, especially those with refractory or relapsing disease, or at an increased risk of glucocorticoid-related adverse effects. In all of those cases where you have a choice of both the drugs, current guidance on safety of both the agents must be considered, and methotrexate can always be used as an alternative. Recommendation 8 is about the use of adjunctive therapy in Takayasu. There are no new data for this, and this is largely unchanged. And we are saying that in all patients, adjunctive therapy with non-biologic disease-modifying agents should be given if they have Takayasu. Tocilizumab or TNF inhibitors can be considered in case of relapsing or refractory disease despite therapy with conventional DMARDs. 9 pertains to relapse and the diagnosis of relapse. So the diagnosis of relapse of PMR and GCA should be based on assessment of clinical signs, symptoms, and laboratory markers, supported by imaging where needed. In Takayasu, the diagnosis of relapse is substantially based on imaging in conjunction with clinical and laboratory assessment. We are recognizing over here that patients with GCA may present with a completely new symptom at relapse as compared to a diagnosis, and they may relapse in a completely different arterial territory, and therefore you would need to look quite thoroughly in the relevant areas. And of course, we know that GCA may present as PMR in relapse, and PMR may relapse as GCA, so that needs to be taken into account as well. Recommendation 10 pertains to the diagnosis of refractory disease. Patients with refractory PMR, GCA, or Takayasu should undergo a re-evaluation of the diagnosis and should be considered for referral to a specialist center. I have certainly seen, and all of us have, patients with refractory disease actually having rheumatic diseases or malignancies or other vascular disorders like Burgess disease and FMD. Recommendation 11 pertains to surgical interventions, and the change from last time is that we have included GCA over here as well in recognition of the extracranial involvement of arterial tree in GCA. In GCA and Takayasu, elective endovascular interventions or reconstructive surgery should be performed in phases of stable remission. Arterial vessel dissection or critical vascular ischemia requires urgent referral to a vascular team. So what we're saying here is that in all instances, try and ensure that your patient is in stable remission before the surgeon tries to operate on them. But there will be times when you do not have that luxury, in which case you have no choice. Yesterday, I told you and showed you some data on open interventions having higher primary patency rates, but endovascular interventions having a low risk of stroke. So take local expertise into account. Recommendation 12 is about follow-up. So in patients with PMR, GCA, and Takayasu, regular follow-up and monitoring of disease should be based on symptoms, clinical findings, and acute phase markers. Imaging should be used to assess for damage on an individual basis in patients with GCA and to assess for activity and damage in all patients with Takayasu. You will have seen that all of these recommendations have a really high level of agreement, and this is quite unusual in the recommendations that I have had the privilege of, the task forces that I've had the privilege of being on. So in the end, I commend these recommendations to you and urge you to use these in your daily practice. These, I'll take you through and show you these algorithms once again. Thank you very much, and I'm happy to take questions.
Thank you very much indeed for this excellent presentation. And so do we have any questions from the audience? Yes, there are many questions. So before I go to the audience, questions for myself. So in the recommendation 6, I think you said that tocilizumab can be used as adjunctive therapy in selected patients for PMR, with PMR. So do we have any evidence or expert opinion about which patients are these? I mean,
So we have evidence that tocilizumab works in those patients. We have clinical trial evidence, and there are going to be, there isn't an evidence base for which patients they should be used in, but this is in situations where you instinctively feel like glucocorticoids are not in the patient's best interest, or you want to really minimize the dose, that they may have had previous mental health problems or neuropsychiatric issues, or that they have difficult diabetes or heart failure, and you really want to lower the burden, then that's a really great option now.
Thank you very much. Question?
Thanks a lot for your wonderful. Thanks a lot for you. Thanks a lot for your wonderful talk. I have a question about the stop of sarilumab and tocilizumab in polymyalgia rheumatic patients.
Sorry, say that again.
I need information about the stop of sarilumab and tocilizumab in polymyalgia rheumatic patients after the withdrawal of corticosteroids.
So, if I understand correctly, are you asking how do you withdraw after well, that's an easy question for me in this country, because I don't have access to sarilumab or tocilizumab right now. But when we have access, but when we have access, my answer is that if you look at the data and look at in tocilizumab, for example, I think I would probably go to, if you're using subcut, then go to every other week to begin with. And if that's okay, I'll stop it. But you're going to have to use the same strategies as you use in other diseases when you're tapering. There's no different strategies.
There is one more question at the back.
Kush Dallas, thank you very much. It was an excellent presentation and very helpful. I am surprised, however, on PMR and GCA that you have steroid sparing with the IL-6 inhibitors. That makes good sense. And then put on the same slide methotrexate. Is that to say, and so there's no strength of this agreement, which is great, but no strength of evidence provided. I assume that you'll do that at some point, but do you really intend to put methotrexate on the same level as IL-6 inhibitors?
So we have said that we can use methotrexate in those patients because we are, number one, there is, yes, I agree, there is a limited degree of evidence compared to those two. I completely agree. But we have also taken into account the fact that, number one, it's a drug that we're all familiar with, and number two, the access to these drugs is going to be very restricted in patients, especially for PMR, where tocilizumab is not even licensed. So we're taking into account the access as well.
There is one more short question, please.
Question. If we see all the patients with PMR, then are we expected to do PET-CT on all of them? Because how would we distinguish? Because traditionally we would see the patients who did not respond to 15 milligrams and take it from there. But if all of them look the same, how do we stratify them?
So that's where the clinical skills do come in, and I think if you have patients with polymyalgia rheumatica where you have constitutional symptoms, the CRP is significantly higher, they have axillary or subclavian arterial bruits or carotid bruits, then those are your markers to tell you that this person may have something more than just PMR. So those are the ones that you definitely want to image. Yes, I agree that the jury is out on how many patients with PMR should you image. I personally image all of them, but that's not the recommendation. And the task force felt that in a significant number of patients, you might be able to get away without imaging. But if there were any red flag symptoms, then yes, you do need to get to imaging.
So thank you very much. It was great to having you here.
So we move on to the next speaker, and it's my pleasure to introduce Professor Oriel Khayyam and the update of recommendations for vaccination in patients with autoimmune rheumatic diseases. Thank you.
Okay. Okay, thank you very much for the opportunity to present the 2026 update of EULAR recommendation for vaccination in patients with rheumatic diseases. So I'm the convener of this task force. My co-convener is Professor Muller-Ladner, Vika Fuhrer, Dafika Pelushnik, Alessia Luno, and myself performed the SLR. Robert Landeve was our methodologist, and he was assisted by Kim Loper as a co-methodologist. So, as you know, the first EULAR recommendations for vaccination were published in 2011 and then updated in 2020. But since then, the world has gone through the COVID-19 pandemic since vaccines. There are new vaccines such as the recombinant zoster vaccines and other very interesting studies on vaccine strategies in patients with rheumatic diseases. And therefore, the EULAR endorsed this task force to update the recommendations. So this is our task force, which consisted of 25 members from 9 European countries and Israel. We were most rheumatologists, but there was also a specialist in infectious disease. And we formulated the recommendation at our third meeting, which was held in Zurich on February 26. Before I start, I would like to remind some core definitions which are important for the understanding of study endpoints in vaccination studies. So we have the first term of efficacy, which is the ability of a vaccination to prevent infections or disease in direct clinical endpoints. We have immunogenicity, which is the ability of a vaccine to induce humoral and or cellular immune responses, frequently used as surrogate endpoints in studies on autoimmune rheumatic diseases. And we have the safety, which is the evaluation of both vaccine-related adverse events and the potential risk of aggravating the underlying rheumatic disease. So these are the 4 research questions which form the basis for our SLRs. First, what is the incidence, prevalence, and outcomes of vaccines-preventable infection in adult patients with rheumatic diseases? Second, what is the efficacy, immunogenicity, and safety of available vaccines in patients with rheumatic disease, whether treated or untreated with corticosteroids, DMARDs, and other immunosuppressive agents, including the timing of vaccination in relation to treatment and disease activity? The third question was divided in 2 parts. 3A, what is the effect of vaccination of household contacts of patients with rheumatic diseases on prevention of VPI and on safety outcomes in patients with rheumatic disease? And 3B, what is the efficacy, immunogenicity, and safety of vaccination in neonates with 2nd or 3rd trimester exposure to biological therapies? And the last question was, what is the efficacy and safety of post-exposure prophylaxis in patients with rheumatic disease receiving immunosuppressive treatment? And these are the flow chart of the search for PICO1 and PICO2. You can see here that for PICO1, we extracted data from 62 papers, from PICO2, 45 papers. There were no relevant studies for 3A, and we found data for 3B with 8 papers on immunogenicity and 10 on safety. We did the same search, which was led by Alessia, on COVID-19. And we could find for PICO1 and 2, 58 papers and 1 paper for PICO4. So we formulated 5 overarching principles and 10 recommendations. So these are the 5 overarching principles. I will start with overarching principle number 5, which has not been changed from the previous recommendation. And it states that live attenuated vaccines may be considered with caution, and I will come back to that when I address the issue of yellow fever vaccine. So overarching principle 1 states that vaccination status and indications for further vaccination in patients with rheumatic disease must be assessed at diagnosis. This is a key change from the previous recommendation, and yearly thereafter by the rheumatology team. So this shifts the focus from mid-treatment review to proactive day zero planning, integrating infection prevention before immunosuppression begins if it is possible. Overarching principle 2, an individualized vaccination program and its implementation should be discussed with the patient by the rheumatology team using a shared decision-making approach, and this is a more collaborative risk-adapted care. Overarching principle 3, in general, patients with rheumatic disease should be vaccinated as soon as possible, independent of disease activity, and preferably before the initiation of immunosuppressive treatment, especially B-cell depleting therapy. And this is the main change from the previous recommendations, since we removed the prerequisite for quiescent disease, and we put emphasis on vaccinating as soon as possible, of course, when it is possible. Overarching principle 4, non-live vaccines can be administered safely to patients with rheumatic disease regardless of treatment. So here the emphasis is on the safety. So these vaccines are safe. In terms of immunogenicity, it depends, of course, on the underlying immunosuppressive treatment. So let's move to the 10 recommendations. As you can see here in the bottom of each slide, you will see the strengths of recommendations and the level of agreement. So recommendation number 1, influenza vaccine is strongly recommended for patients with rheumatic diseases. And the second part is new, holding methotrexate for up to 2 weeks may increase the yield of vaccination. This is based on several studies from the group of South Korea, from PARC, who have evaluated different strategies of holding methotrexate after vaccination from 1 week, 2 weeks, 4 weeks, in comparison with continuing methotrexate. And it could show that the immunogenicity was improved when holding methotrexate, and the best period of holding is 1 to 2 weeks, since it doesn't affect disease activity. The task force also discussed the topic of high dose versus standard dose influenza vaccine. There have been several studies. For example, there is a study called MEGNA from Canada, which evaluated the immunogenicity of the high dose vaccine in patients with rheumatoid arthritis on TNF-alpha blockers. And they could show that the immunogenicity is much improved in comparison with standard influenza vaccine. However, another study from Stapleton, for example, was less conclusive, so the task force decided not to include it in the main recommendation, but you certainly can consider vaccinating your patients with a high-dose influenza vaccine if it is available in your country. Recommendation number 2, pneumococcal vaccination is strongly recommended for patients with rheumatic diseases. This is based on the fact that there is an increased burden of invasive pneumococcal disease and severe pneumonia. For example, the increased rate ratio, the incidence rate ratio of is 4.3 for SLE and 4.4 for RA. And we recommend the conjugated vaccines according to local guidance. This is an evolving field, so now for most countries, we use the Prevnar 20, but there is already the Prevnar 21. And anyway, most of the studies have been performed on the conjugated vaccine Prevnar 13, and they have shown a good immunogenicity in patients with lupus, rheumatoid arthritis, vasculitis. I would like to mention a very interesting study from Jacques Morel from France. This is a similar study which recruited patients with early rheumatoid arthritis and randomized them into groups. The first group received PCV13 with methotrexate and started methotrexate, and the second group received PCV13 and the methotrexate was delayed for 1 month, and the immunogenicity was much improved in the group of patients who delayed methotrexate for 1 month, after 4 weeks after the PCV13 and also 1 year after, without affecting disease activity. So this is another strategy that we may apply. Recommendation number 3, tetanus vaccine, it was not changed from the previous vaccination, and it said that we should go according to the local guidance, which is usually every 10 years. Recommendation 4, hepatitis A and B vaccines should be administered to rheumatic disease patients at risk, and you can see here the definition of at-risk patients, and we decided to recommend it only for patients at high risk because the prevalence of overt or occult hepatitis B is relatively low among patients with rheumatic diseases. The second part of this recommendation is new, and it states that in non-responders, a booster against hepatitis B is recommended, and in specific situations, passive immunization is recommended. This is based on the fact that there have been several studies which have shown reduced immunogenicity of the standard 3-dose of hepatitis B vaccine. And on the other hand, other studies which have shown that a booster of 2 additional doses may improve the immunogenicity. So we now recommend to vaccinate with the standard dose of hepatitis B vaccine to evaluate the level of anti-HPS antibodies, and if it is below 10, to consider boostering these patients with 1 or 2 additional doses. Recommendation number 5, herpes zoster vaccination is strongly recommended in patients with rheumatic disease who are treated with immunosuppressive treatment, and this is a main change from the previous vaccination, and this is because in the last previous update, we had only the live attenuated vaccine, which has a great limitation, and of course the game changer is the recombinant zoster vaccine. But I would like to remind you that there is an increased rate of herpes zoster in patients with rheumatic disease. We did in the PICO-1 SLR, we had 45 studies which have been published since 2020 on the incidence rate of herpes zoster in patients with rheumatic disease. And you can see here the meta-analysis that was performed by Daphne Kapelushnik. And you can see that there is an increased rate of incidence rate in patients with RA, especially treated with JAK inhibitors, biologics, conventional DMARDs, sometimes with serious outcomes. And it is even further increased in patients with SLE, especially in younger patients with lupus nephritis and during induction, and often with severe outcomes. And in addition, we have 12 studies which have been published since 2020 on the efficacy, immunogenicity, and safety of the recombinant zoster vaccine. As such, we have a post-hoc analysis of the pivotal trials which evaluated the recombinant vaccine in the general population, but they included also some participants with at least one rheumatic disease. And they could show that the vaccine efficacy against herpes zoster was 90%, with adverse events similar to placebo. There are also real-world studies showing reduced herpes zoster risk after vaccination in patients with RA, lupus, and broader rheumatic disease cohorts. Overall, the recombinant vaccine was highly immunogenic and with mild adverse events. And for patients on JAK inhibitors, the humoral immunogenicity, for patients on JAK inhibitors who received during treatment the herpes zoster vaccine, the humoral immunogenicity is preserved, but there is a low cellular immunogenicity. Recommendation number 6, yellow fever. Vaccination against yellow fever should be generally avoided in patients with rheumatic disease, so this is unchanged from the previous recommendations. However, I must say that there have been 2 new studies which have been published in the last recommendations from Brazil, which evaluated the immunogenicity and the safety of the primary vaccination with the yellow vaccine in patients with rheumatic diseases at low level of immunosuppression. And you can see here the definition of low-level immunosuppression, or after temporal withdrawal of more intensive immunosuppressive or biologic therapy. And the yellow vaccine was generally well tolerated with no serious adverse events and no increase in disease activity and a good immunogenicity. However, the task force felt that this is not enough in terms of safety to change the recommendation of avoiding the yellow fever vaccine administration. However, I think that these 2 studies provides us some flexibility, and in certain situations we may consider vaccinating patients against yellow fever if they are definitively on a low level of immunosuppression. Recommendation number 7, vaccination against HPV is strongly recommended in patients with rheumatic diseases in accordance with recommendations for the general population. And we have an additional sentence, which is catch-up vaccination is especially recommended in SLE patients. This is to emphasize the need for HPV vaccination in patients with SLE. This is based on the fact that the prevalence of HPV is increased in patients with SLE, and we also have a new important study from the Danish patient registry, which includes more than 5,000 SLE patients, which have shown twice the risk of cervical precancer and up to 5-fold increased risk of non-cervical anogenital precancers in patients with SLE. Recommendation number 8 and 9. Recommendation number 8 refers to household contacts of patients with rheumatic diseases, and it has not been changed from the previous recommendations, and we encourage immunocompetent household members to vaccinate, to receive vaccines, to be vaccinated per national guidelines. This is an expert opinion, common sense, and there is no new evidence on this. Of course, we should, we should exclude the oral polio in this context. The recommendation number 9, it is a main change from the previous recommendation, and it states that in newborns exposed in utero to biological DMARDs, live vaccines should be generally avoided until 6 months after delivery. As an exception, rotavirus vaccine can be given to infants with antenatal exposure to TNF-alpha. This is mainly based on observational studies from patients with ABD, mothers suffering from ABD, and neonates who have been exposed to TNF-alpha blockers at the last trimester of the pregnancy. And there are a few hundreds of infants who received the rotavirus vaccine with no severe adverse event or any safety signal. So this is the basis of this change of the recommendation. And of course, recommendation number 10, which is a new one, because we incorporated the COVID-19 vaccine in this recommendation update, and the anti-SARS-CoV-2 vaccine is strongly recommended in patients with autoimmune rheumatic diseases. This is backed by 58 SLR studies, which demonstrated a highly favorable benefit-risk profile, adequate immunogenicity, and safety across autoimmune rheumatic diseases. Of course, you have many topics for the research agenda. As you can see here, we need more data on clinical effectiveness, on durability of vaccines, on the new therapies such as CAR-T and bispecific, etc. We have new vaccines such as RSV. For them, we do not have any studies in patients with rheumatic diseases, and we hope that we will have in the future. So what are the major conceptual shifts in these recommendations? First, the 2026 update provides an implementable framework that replaces hesitation with proactive protection. Vaccinate early, regardless of disease activity. Non-live vaccines are safe across treatments. Temporarily modulating methotrexate may improve immunoprotection. There is a strong recommendation for the recombinant zoster vaccine. Newborns exposed in utero to TNF-alpha blockers may be vaccinated against the rotavirus. And of course, we incorporated the COVID-19 vaccine. And these are the members of the task force. Again, I would like to thank my co-convener, Ulf Muller, Vika Forer, Dafka Pelushnik, Alessia, Robert Landbeve, and Kim Lauper, and of course, all the members of the task force who contributed very much to the discussion of the task force and to the recommendations themselves. Thank you very much.
Thank you very much. And we have one question from my co-chair.
Thank you very much for this excellent presentation. So I think it was recommendation number 5 about herpes zoster, that it is advisable to vaccinate all immunosuppressed patients. So, for example, in the field of rheumatoid or psoriatic arthritis, these patients would be all patients or just patients who are on biologic DMARDs?
No, all patients, even patients on conventional DMARDs. Yes, absolutely.
Thank you very much.
We have time for one more quick question. Thank you.
Yeah. Thank you very much. Very clear. Please, can I ask some clarification about these new guidelines with respect to patients where treatment cannot be delayed, for example, vasculitis?
I cannot hear you very well, so perhaps louder.
In patients who must start treatment, for example, patients with GCA, who must go on to very high-dose steroids, do your guidelines still stand true? And how would you approach a patient on 60 milligrams of prednisolone?
Okay, this is an excellent question, of course. And in fact, in these patients, we recommend to postpone the vaccination because we believe, well, there are some studies about that the immunogenicity of the vaccine in patients treated with prednisone with an equivalent dose of 15-20 milligrams, above that, probably the immunogenicity is very much decreased. So although these patients are at higher risk when they are on 60 milligram prednisone, but for now, well, we know that well, we have heard in the last presentation that up to 2-3 months, we can reduce the dosage, and then for this patient, I will vaccinate them when they are on lower doses of prednisone.
20 milligrams or less?
Yeah, 15 to 20 milligrams, yes.
Thank you.
Okay, so we thank you very much again for the presentation.
And we now would like to invite Peter Mandl, a clinical researcher and associate professor at the University of Vienna, to present the 2025 EULAR recommendations for the use of imaging in the diagnosis and management of spondyloarthritis. So, Peter, the floor is yours.
Thank you very much, George, Alessia, and thank you everybody for choosing our session. These are my disclosures. I'd like to begin by thanking my co-convener, Mikkel Ostergaard, in particular our two lovely fellows, Susanna and Clara, who had posters on their SLRs, one of them yesterday and one of them today. Our methodologists, Victoria Navarro-Compan and Delphine Courvoisier, and of course the members of our task force who came from 12 different countries. As you well know, SPA is a group of diseases with shared characteristics, including sacroiliitis, spinal inflammation, peripheral arthritis, and enthesitis, again highlighting the importance of imaging. And it can be generally divided into peripheral SPA and actual SPA, which is going to be reflected in the recommendations. And imaging has been a part of basically every classification and diagnostic criteria in both of these manifestations over the years. And the imaging recommendations reflecting these were published in 2015. At the time, they had no overarching principles, 10 recommendations, and also no implementation plan, which was not a necessity or a request or in the EULAR SOPs at that time. So why update? These recommendations have been cited by 750 publications and served as the basis for recommendations and guidelines by national societies, our colleagues in the musculoskeletal radiology field. However, they reflect literature that was published until 2012, so they are about 13 or almost 14 years old. And there's been rapid developments in the technology, both with regards to MRI, ultrasound, and CT over the last 15 decades, and so it was thought that it would be timely to perform this update. Just briefly on the scope, so this would include the both actual and peripheral SPA, including PSA, radiographic as well as non-radiographic SPA, would focus only on MSK involvement. This again reflecting the original recommendations, would consider essentially all commonly used imaging methods, radiography, CT, MRI, PET, SPECT, scintigraphy, looking at the utility of imaging in its full role, diagnosis, monitoring both of inflammation and damage, predicting outcome and treatment effect, and also two topics which are relevant for SPA osteoporosis and spinal fractures. And the application against clinical practice, not research. These are the objectives, again, very much in reflecting what is requested of such a task force. The methods, according to the SOPs, 12 research questions were discussed and actually adopted from the original recommendations, so you don't need to read these in detail. 2 of them focused on diagnosis, 4 on monitoring, additional 4 on prediction, and then the final 2, which I mentioned, on these specific aspects. The SLRs, 2 SLRs were performed, a total of almost 7,800 abstracts reviewed, and risk of bias assessed for all of these studies, and again, the full range of imaging modalities evaluated. This is just a brief overview of the number of papers that were included, and I just want to highlight here or point out that particularly for the predictive questions as we go along, the research questions, we had of course less and less studies and therefore more expert opinion. And so the recommendations and the overarching principles themselves, and again, these are completely new. Imaging should be selected where imaging modalities taking into consideration the clinical indication, contraindication, radiation exposure, availability, patient concerns, and costs. It should be performed in accordance with international and national guidelines. And again, important to highlight that, of course, we share imaging with our radiology colleagues. And it's important to follow these guidelines. It's important to realize that MRI is not MRI per se, but it has about 100 different sequences nowadays, and these, of course, should be taken into consideration when selecting the modality, the equipment, acquisition, analysis, interpretation. The findings that we find on the imaging should not be interpreted in isolation, but should be considered in the context of demographic, clinical, and laboratory information. And these principles were also important because they allowed us to reduce the length of the recommendations, which was one of the criticisms that were received when they were published, because some of them were quite long. And now for the actual recommendations, I will try to show, or I'll show in each case the old recommendations. And again, I'm well aware that this is a very long test, and we had a great night last night, so you don't have to read all of this. But concentrate on the new recommendations, and I'll point out what we ended up changing. So in the update, instead of conventional radiography, which was recommended as the first imaging modality for diagnosing actual SPA, MRI is now recommended. Both inflammatory and structural lesions should be considered. This has not changed. And additionally, MRI of the spine is now recommended. This was not recommended, not generally recommended to diagnose actual SPA in the old recommendations. Kind of highlighting the fact that it provides important differential diagnostic information if we think about DISH or degenerative spine disease. And only if MRI is not available or contraindicated should radiography or preferably low-dose CT, and again, the preferably is an important word here, reflecting the increased sensitivity of low-dose CT and the very low doses of radiation, which are sometimes below that of radiography. So for the second recommendation, this one on, again, still on diagnosis and peripheral SPA, here is the old recommendation, which recommended ultrasound or MRI. The new recommendation still recommends ultrasound MRI, should be performed to detect inflammatory and or structural lesions. And again, to reduce the length, we are not listing these lesions, but of course that is included in the text. And then in addition, radiography is now also recommended or can be performed to provide additional information on structural damage. This was not part of the old recommendations. Recommendation 3 is actual SPA and monitoring activity. There, the old recommendations suggested or recommended MRI of the SI joints and or the spine to assess and monitor this activity in actual SPA. So this recommendation was not revised but reworded, which means that there was no major change in the type of modality or the region. Okay, so it's still MRI of the SI joints and the spine, and simply the word may was changed to can. And again, the length was reduced. You can see that, which I didn't mention yet, that for all of these recommendations, the level of agreement was extremely high, above 9.4 for all. Recommendation 4, actual spondyloarthritis, monitoring structural damage. The old recommendations recommended conventional radiography of the SI joint and the spine to be used for long-term monitoring of structural damage. And MRI was mentioned as able to provide additional information. We also included the text at the time that if performed, the X-ray should not be repeated more frequently than every second year. Again, the new recommendations have now replaced conventional radiography with MRI for monitoring structural damage in the SI joint and the spine as the first suggested modality, but of course radiography remains and can be used for long-term monitoring of structural damage. And additionally, low-dose CT is now also mentioned in this recommendation, reflecting the evidence. Has being able to provide additional information on damage in the sacroiliac joints and the spine. Recommendation 5, monitoring activity in peripheral spondyloarthritis. The old recommendations recommended ultrasound and MRI to be used to monitor disease activity in peripheral SPA. And again, some additional sentences on when to repeat depending on the clinical circumstances, as well as a sentence which mentioned that contrast agents are generally not needed and ultrasound with high-frequency color or power Doppler is sufficient. These aspects have now been moved to the text, again, to come up with a shorter, more succinct recommendation. Ultrasound and MRI can be used to assess and monitor disease activity in peripheral SPA to assist treatment decisions. So again, no major change in the kind of imaging modality recommended, and slight change to wording. Recommendation 6, how to monitor structural damage in peripheral SPA. So in the updated recommendation, radiography, MRI, and ultrasound are all mentioned at the same level. The previous recommendations recommended conventional radiography first in the first line, and MRI and ultrasound as being able to provide additional information. This recommendation, again, reflecting the evidence that arose over the last 15 years, mostly on ultrasound and MRI, it being able to show or utility for monitoring structural damage, and particularly in PSA. Most of the, perhaps important to mention, most of the recommendations for peripheral SPA in terms of monitoring and prediction were on PSA populations. You can also see, by the way, in these tables, in addition to the level of evidence, greater recommendations, according to the new SOAPs, the task force also voted on impact and feasibility and priority of these recommendations, and that those are the numbers in the right part of the tables. And again, seeing that for most of these, again, the impact and feasibility were all rated quite high. Recommendation 7, predicting outcome or severity in actual SPA. Old recommendations mentioned specifically ankylosing spondylitis here, and recommended conventional radiography of the lumbar and cervical spine to detect syndesmophytes, which were predictive of development of new syndesmophytes, and MRI was recommended as a tool that may also be used to predict development of new radiographic syndesmophytes. In the new recommendations, again, similarly to recommendation 1 and recommendation 4, MRI is now replacing conventional radiography as the method of choice to detect both inflammatory and structural lesions both in the sacroiliac joints and the spine to predict structural progression. including the development of new syndesmophytes. And additionally, in the second sentence, the task force opted, of course, to maintain radiography and include also low-dose CT. And the syndesmophytes detected by these techniques has been able to predict the development of new syndesmophytes. So moving along, recommendation 8, this is predicting a treatment effect in axial spondyloarthritis. The old recommendations mentioned extensive or recommended extensive MRI inflammatory activity, particularly in the spine in patients with ankylosing spondylitis, has a predictor of good clinical response to anti-TNF therapy in axial SPA. The new revised recommendations will maintain the extensive MRI-detected inflammatory lesions, but in this case include, in addition to the spine, also the sacroiliac joints, and all of this in the framework of axial SPA rather than ankylosing spondylitis alone. An additional change is that the task force replaced the anti-TNF alpha with the more broader biological and target synthetic DMARD category, again reflecting evidence on interleukin-17 inhibitors and JAK inhibitors, and also included another sub-sentence reflecting some of the evidence from studies that have been able to show that it is able to also to predict flare in patients in clinical remission when considering tapering. Recommendation 9, this is the only recommendation which is a new recommendation predicting treatment effect on peripheral SPA. So there was no old recommendation on this because there was simply very low evidence. And now a few studies have been published which have shown that higher structural damage on radiographs it may predict structural progression, and that is reflected in the very short text of these recommendations, which is recommendation 9. And finally, the last recommendation is on spinal fractures. So again, this specific feature or characteristic of spondyloarthritis. The old recommendations recommended X-ray, conventional radiography, has the recommended initial imaging method. And if conventional radiography is negative, then CT should be performed. MRI is an additional imaging method to CT, which can also provide information on soft tissue lesions. In the updated recommendations, we are now, or the task force is now recommending CT and MRI and or radiography. Again, reflecting the fact that CT is able to detect certain fractures that radiographs cannot, and also the fact that MRI, and particularly in patients who have neurological symptoms or where this is suspected, should be outruled, then should be performed if possible, whenever possible. I'd also like to point out, maybe before you ask, the word conventional was removed in every recommendation before radiography. This was an important comment by our radiology colleagues, whom we had 4 on the task force. It was extremely valuable to have them on, of course, because most of the radiographs nowadays are digital. So that is why we have to stay with the term radiography, so don't say conventional radiography anymore. And in a second sentence in these recommendations, the task force considered it very important to highlight that the presence of ankylosis makes it very difficult to detect fractures on X-rays, and therefore CT and MRI should be used in these cases. As I mentioned in the beginning, the old recommendations did not have an implementation plan. That was at that time not a prerequisite on the EULAR SOPs. It now is, and for that reason, the task force also came up with an implementation plan on a few particular aspects. These are those recommendations which were rated as having the highest priority. Not surprisingly, diagnosis for both for axial and peripheral SPA, and monitoring activity for axial SPA. And here you can see some suggestions of what we would like to measure, and the suggested methods would be chart reviews of selected tertiary centers, as well as a survey of EULAR national societies, essentially trying to then map about 3 years after we publish the recommendations, which will be submitted to the QOC committee, hopefully very, very soon. Percentage of patients with a suspected AXPA on whom an MRI is performed for diagnostic purposes. Similar plan for peripheral SPA in terms of ultrasound and MRI. And then a percentage of rheumatologists applying MRI for making treatment decisions in actual SPA for the monitoring activity part. So to conclude, The task force formulated 3 overarching principles, and these were new and again allowed us to frame the recommendations and also allowed us to significantly reduce the length. 10 specific recommendations were formulated, 2 on diagnosis, 4 on monitoring, 3 on prediction, and 1 on spinal fractures. Just like to point out that there were 2 research questions for which no recommendations were formulated. These were recommendation 10, predicting treatment in peripheral SPA. This is similar to the old recommendations where we also had no recommendation on this, and unfortunately there has been not a lot of studies providing evidence for this, and those which were included, those very few had high risk of bias. And also for research question 12, osteoporosis, the task force did not formulate a recommendation, and is referring to national and international radiological guidelines in this regard. Of the 7 recommendations revised, 2 recommendations were rewarded, and we had one new recommendation. And again, pointing out that the level of evidence for the recommendations as well as the level of agreement was very high. And with that, I'd like to thank you for your attention and thank again the task force, our fellows, methodologists, and my co-convener, and you for your attention.
Peter, thank you very much for this excellent presentation and for also discussing the implementation plan, which is a very important aspect of the EULAR recommendations. So I see that we have 2 questions there.
Hi, thank you very much for your talk. You might have touched on it, so I'm sorry if I missed it, but are there any recommendations to image the whole spine at diagnosis in terms of establishing disease activity and predictors of progression?
So the short answer is no. The whole body MRI is not mentioned in the recommendations themselves. It is discussed in the text, pros and cons.
Okay, thank you.
Thank you very much for the presentation. Can you hear me well?
Now I can. The second sentence is much better, Alexander.
All right. So, so we, as a community, in the SPA community, we struggle to invite our colleagues to use ASDAS to monitor disease activity, and even then, it's sometimes difficult to implement. With that being said, in which patients do you think that, in addition to doing an ASDAS to monitor response to therapy, that we should also perform an MRI?
Okay, I think you're referring to monitoring disease activity. Okay, so that is number 3. Well, in any clinical scenario where you are considering changing your medication, where you are wanted to look at differential diagnosis, this is again outlined in the text. Again, what the aim was to make very succinct recommendations, and I think the wording we use here is to assist treatment decisions.
Okay. In addition to ASDAS, in some patients we should perform an MRI.
I completely didn't get this question. Sorry.
So my question is, in addition to doing an ASDAS to make a treatment decision, we should perform an MRI. Is that correct?
Yes. So in the previous recommendations, we had sentences on top of, conventional disease activity measures, serological markers and such, and that is now all discussed in the text of recommendations. Again, trying to make them shorter. Yes.
And the final short question, short answer.
Yeah, thank you for summing up a recommendation that we developed. This is Christina from Czech Republic. I just wanted to add that maybe we should mention that one of the recommendations disappeared about the osteoporosis and the screening of it.
Yes, again, so that is discussed in the text, and I mentioned this here briefly. The task force discussed this really extensively and thought particularly the feedback of the radiology community was very important here, that is better, framed and recommended by the existing radiology guidelines, and we refer to that, yeah.
I think this worked. It was great to have you here. Great, thank you.
Thank you, George.
So we now move to the last presentation, Professor Lorenzo Cavagna from Italy, and presenting the 2025 EULAR ACR classification criteria for antisynthetase syndrome.
Thanks a lot.
to Chairperson. Thanks a lot to all people that are here on Saturday. Now I'm presenting the classification criteria of antisynthetase syndrome that are at the final approval from the ACR. These are my disclosure. You know perfectly antisynthetase syndrome. You know that it's a condition that is characterized by arthritis, myositis, interstitial lung disease, and different manifestations and different biomarkers not limited to antisynthetase antibodies. But you know that the number of antisynthetase antibodies is steadily increasing. Every year we may discover new autoantibodies that may change the paradigm of this condition. And we have a reason. We have a reason because we have 20 aminoacyl tRNA synthetases, and we have 20 potential autoantibodies that could lead to the occurrence of the antisynthetase syndrome. But we have also other factors because aminoacyl tRNA synthetase are occurring in macro complexes. So we may have also cross-bridging autoantibodies that may increase again and again the number of potential autoantibodies. Then we have also other issues that we should consider for the difficulty of the diagnosis, because sometimes we may observe patients with more than one myositis-specific autoantibodies, including antisynthetase antibodies. Maybe that we could have a problem in false positive and false negative results. Maybe that commercial kits are not including our antisynthetase antibodies, and also the testing may be not widely available. So we have a lot of knowledge about the clinical presentation, but we have a lot of problems about the testing for these autoantibodies. But although we know the disease, we have different definition in literature. So this is a problem because different studies may define antisynthetase syndrome in different ways. So it's time for you to bring your mobile phone and we will play, because this is a voting question. Observe, start voting. All answers are okay. We have not wrong answer. I'm presenting different combinations of clinical manifestation. So, okay, probable antisynthetase syndrome is the most voted answer, but however, we have also some colleagues that defined it as definite, and other IPAF, and other idiopathic pulmonary fibrosis. As I told you, all answers could be completely correct. Next slide, start voting again. Now the clinical picture is changed because we have a UIP, but now the patient is positive for antigen 1 antibodies. Okay, that's perfect. We have different kind of answer, but the most voted is defined antisynthetase syndrome. Next slide again, start voting. Now we have mechanic hands in addition with respect to previous picture. Okay, that's perfect. The majority of us reported as a diagnosis definite antisynthetase syndrome. Now, another question is not boring, it's useful for us. So in this case, we are not antisynthetase antibodies positive. But we have all the features that could be associated with antisynthetase syndrome, including anti-Rho52 positivity and anacytoplasmic positivity. Oh, it's intriguing because a lot of people showed that the diagnosis is definite or probable antisynthetase syndrome. Again, clinical evidence of myositis, Gottron papules, anti-Me2 positive, and anti-OJ borderline with a commercial dot.
diagnosis in the majority of cases dermatomyositis, but someone defined also the possibility of an overlap or also definite and probable antisynthetase syndrome. And in this case, we have the full positivity of anti-OJ antibodies, not borderline, so with a stronger evidence. Okay, a very wide range of answers, for sure, this is important. And this is the reason, the difference in your answer is the reason that led us to ask for the classification criteria of antisynthetase syndrome. And the team was born in 2017, thanks to the collaboration between me and Roy Tagarval. And as you know, we had a lot of people with CLASS because the name of the project was CLASS Project. And I want to say thanks to all people that has been involved in the management of this huge work. We had two main problems in the study. First of all, pandemic, as all of us. The second one is that we planned to enroll 400 patients, but you may see that at the end we included more than 2,000 patients, so it was very, very impressive. I presented 1 year ago the structure of the project in Barcelona, and we published 2 works on annals of rheumatic disease and on arthritis and rheumatology, so I'll go directly to classification criteria. We divided the classification criteria in different domains. The clinical domains that included the classic triad of the disease, arthritis, myositis, and interstitial lung disease. Then we added another section that is including manifestations such as renal phenomenon, mechanic ends, inflammatory rashes, and then the serological domain. We divided the serological domain. We split antigen 1 with respect to non-antigen 1, according even to occurrence of test and lab test analysis with immunoprecipitation. We included anti-Rho 52 positive because you know that anti-Rho antibodies might be positive in up to 50% of cases, and we have also a huge prevalence of antinuclear antibodies positivity with a cytoplasmic pattern. When we should not apply our criteria? If we have a clinical picture that is fully consistent with another condition, a dermatomyositis, is not necessary to go more in depth. It's crystal clear, it's simple, and all people are in agreement for sure with this definition. And these are the criteria. You may see that we define a different weight for different manifestation. We included in the definition of joint involvement also inflammatory arthralgias, not full only the occurrence of real arthritis. We divided muscle involvement in the subclinical, clinical, and biopsy supported, and then we divided also interstitial lung disease in UIP and NSIP and other pattern with different weight. You may observe that we included also skin dermatology rashes that are present in our cohort in 20% of cases, and to wait for antigen 1 positivity, which every method you will use is as to the IGE score. On the other hand, for non-antigen 1, the IGE score is only if you are applying immunoprecipitation that is not so diffuse. But we have, please observe, also a weight, important weight for anti-Rho and for anacytoplasmic positivity. We defined this definite antisynthetase syndrome if we are reaching a score higher than or equal to 5.5. We need for sure in this case one clinical domain, arthritis, myositis, or interstitial lung disease, and for sure antisynthetase antibody positivity. It's mandatory. For the definition of probable, the score should be higher or equal to 5. We need, again, the main clinical domain between the classic triad, but antisynthetase antibodies in this case is not mandatory. Obviously, we should evaluate that this patient should be tested subsequently with anti-synthetase antibodies. I reported in one question the borderline positivity. So borderline or indeterminate positivities of anti-synthetase antibodies should not be considered when applying for ASIS classification criteria. It's important to remember that because we may have different degree of false positivity, false negativity, so it's important. In case of multiple positivity of myositis-specific antibodies, including one anti-synthetase antibodies, please consider that this criteria could be applied if we have a strong titer of anti-synthetase antibodies with one single testing or the confirmation of maybe weak positivity into consecutive assessments. And in general, when the positivity of anti-synthetase antibodies is occurring in this patient, anti-synthetase antibodies are ruling the spectrum of the patient. We have preliminary data about that. It's important, however, to remember that we are seeing mechanic ends and other manifestations, even in scleromyositis, anti-PMSCL positivity, and even anti-MDI5 syndrome. So please check always the positivity for these antibodies because we should avoid a misdiagnosis of this condition, in particular for anti-MDI5 syndrome. And these are the answer. I want to report that this is only the final score of different questions I presented to you. It's important to remember that in this case, criteria should not be applied because we have the positivity of anti-B2 antibodies and the clinical spectrum time course of the disease that is fully represented by dermatomyositis. Of note, you may diagnose also dermatomyositis in anti-synthetase syndrome patient because the overlap is possible. Overlap is the typical feature of anti-synthetase syndrome. It may be in overlap with rheumatoid arthritis, with a lot of condition, and even with systemic sclerosis. This is the performance of our criteria. We divided in 4 cohorts our patient, derivation cohort and performance evaluation. 10, we performed the first analysis on the independent validation cohort that included the 25% of cases. Then we included from all the cohort some patients that were tested centrally by immunoprecipitation. We were not able to identify all these patients between the independent validation cohort because of serum amount and so on, some logistic problem. And this are to cut off in terms of sensitivity and specificity in the independent validation cohort and in the sensitivity analysis cohort that included patients that were positive by immunoprecipitation. You may see that the performance is very good, 86.8% and 92.8% in terms of sensitivity, and 99.2% and 99.3% in terms of specificity. You may see here the results we obtained with different changes according to the performance in the independent validation cohort. And in the sensitivity analysis cohort, we choose the best cutoff possible according to the decision of our steering committee. We defined also probable, and also for probable, both sensitivity and specificity were good, really, in terms of in both independent validation and sensitivity analysis cohort. And you may see the performance of our criteria in the independent validation cohort and in sensitivity analysis cohort. But we have a news, because we included also the possibility to classify one patient with a possible. If you have a score that is higher or equal to 4 with at least one clinical domain, not including the main domain, all domains that we know that may appear in anti-synthetase syndrome, we may classify a patient as a possible anti-synthetase syndrome. And in this case, the positivity of anti-synthetase antibodies is not mandatory. The performance was good, even in this case. You may see 96.4% and 98% in sensitivity cohort, and for specificity 75.3 and 80.5 in both in respective cohorts. And these are the performance of our definition of possible anti-synthetase syndrome in independent and in sensitivity analysis cohort. Obviously, we may obtain the upgrade to probable or definite anti-synthetase syndrome in case of appearance of new findings. That is very common, as we showed in different papers that we published starting from 2014, in 2019, and even recently in arthritis and rheumatology. But now I have again a question, the last question for you. Do you think that the definition of possible anti-synthetase syndrome is useful or not? Different degree of agreement you may. Okay, that's wonderful. I really appreciate the point for no idea. It's very wonderful. My compliments for Tiras for this answer. These are the conclusions. This is our manuscript that will be submitted as soon as possible, soon after the okay from the ACR for the approval. They are changing commas and the dots because the concept is perfectly fitting with the definition we have of anti-synthetase syndrome. Thanks a lot.
Thank you very much, Lorenzo. Do we have any questions from the audience? If not, I can start maybe with a quick one. So you were mentioning in the bullet points about retesting over time, and what about the window? I mean, the timing, the weeks?
So it's a very important point because first of all, we should retest patients with the suspect of anti-synthetase syndrome if at the first assessment they are negative. Maybe that we could wait 3 to 6 months. For now, we have no full data to define when you should reperform the testing. But for sure, in case of appearance of new features, that is typical of anti-synthetase syndrome. Then this criteria we wrote that should be up to date regularly, because you know there is a large number of autoantibodies that may be hidden and we may find it. So we need further reassessment. But it's important, in my opinion, to include the possibility to define a possible anti-synthetase syndrome if we have not anti-synthetase antibodies and other myocyte-specific autoantibodies, because we need really to think that this is a protean disease. This is a changing disease. And it is crucial that maybe even possible anti-synthetase syndrome could be followed, because we have to suspect of the evolution. We are talking for rheumatoid arthritis, for example, of the preclinical status of the disease. This is not a preclinical status of the disease, but it could be a pre-anti-synthetase syndrome.
Thank you very much. Do we have other questions? Just a quick one, and then, yeah, thank you.
Thank you, really enjoyed that. Just for a bit of clarification, when you have multiple positive myositis antibodies, how do you, and you just have a positive negative, you don't necessarily get a titer, do you just go on the clinical features and do you use that as a marker to monitor more closely for anti-synthetase complications? How do you work through that?
So generally the double positivity or triple positivity is not so rare as literature said. It is more common than the expected. Our data suggests that when you have a positivity of anti-synthetase antibodies together maybe with Me2 and XP2 and so on, anti-synthetase antibodies are ruling the clinical presentation of the patient. Maybe that you could consider even to repeat after 3 months to testing, because it's possible that maybe we may overread the testing. It's not so easy to read the testing, even in immunoprecipitation. It's a shadow interpretation for sure. But however, I think that repeating the test is an option. But however, if you have a strong positivity, take care, it's correct. The clinical picture is in line with your suspect, even because if you are testing for an anti-synthetase antibodies, for sure you have a strong suspicion. Even because, for joke, we tested myostatin-specific autoantibodies in a cohort of patients that were with psoriatic arthritis, rheumatoid arthritis, and undifferentiated polyarthritis, only with arthritis, no other sign of the disease, and we found to 25% of positivity on myostatin-specific antibodies, and these patients were followed for more than 5 and 6 years. So be careful, ask for a laboratory test only if you know what to do after the result is positive. Otherwise, don't ask.
Thank you very much. And so to conclude this session, I would like to thank all our speakers. We've heard about large vessel vasculitis, we've heard about vaccination, we've heard about antisynthetase syndromes, and we've heard about imaging. So a very comprehensive and interesting session. Thank you very much for joining, and thank you very much for the last minutes of the Congress.